So today's webinar will focus on translational science and academic approaches to value-based care, conclusions from the AIDPH Summer Fellowship. This fellowship is presented in partnership with CareQuest Institute. So I want to say thank you, first of all, to CareQuest Institute for supporting this initiative. We typically have this initiative every summer, and we were able to really strengthen this initiative and make it a bit more rigorous as a fellowship. And so we appreciate CareQuest support being able to do that. And also, in case you didn't see earlier today, we made a very exciting announcement. AIDPH and CareQuest Institute have formed a strategic partnership to support veteran oral health. We hope that you'll visit our website to learn more about this initiative. We're very excited to move it forward. And if you haven't signed up for our email listserv, you can definitely do that to stay updated on projects like this veteran oral health initiative. So just a few housekeeping tips. Number one, I already mentioned this will be recorded and made available via our YouTube channel later. It is in webinar format, so that means that attendees won't be seen on the screen. There will be 3 presentations followed by Q&A. So that means we'll hold all of the questions until later. You can feel free to chat during the webinar with each other, and that's just fine. But we ask that you hold questions until the end and use the Q&A function at the very end to ask questions to the panelists. So we'll save about 10 minutes, 15 minutes at the end for Q&A to our panelists. Lastly, as I already mentioned, 1 hour of CEUs is available for this webinar. We'll put a link in the chat at the very end, and you will also receive a follow-up email that has the evaluation and CEU request. So without further ado, I'm going to introduce all 3 of our fellows today for the AIDPH Summer Fellowship Program who will be presenting their work, and I'm going to do that in order of presentation. So first is Dr. Nithya Ramesh, who graduated from Brown University with an MPH in 2017 and is currently pursuing a doctoral degree from Harvard University School of Dental Medicine, followed by Dr. Amrita Tembhe, who completed her residency in dental public health from North Carolina Department of Health and Human Services, Division of Public Health. And she earned her MPH from University of North Carolina, Chapel Hill. And then she'll be followed by Tooka Zokaie, who is the manager for fluoridation and preventive health activities with the ADA. She leads the National Fluoridation Advisory Committee and the Prevention Subcommittee for the Council on Advocacy for Access and Prevention. And so without further ado, I will leave it to our panelists. Thank you all.
Thank you, Annalise, for the introduction. Hi, everyone. Thank you so much for joining today. My name is Nithya Ramesh, and I'm going to be talking about an environmental scan of US dental schools. The purpose of my study was to provide a snapshot of US dental schools and training related to key elements of value-based care delivery. So my presentation is going to have an introduction where I'll talk about US dental schools, where we're currently at. I'm going to introduce a few key terms. We talk about the methods that I employed and the results and a discussion. So these are the learning objectives of my portion of this webinar. I'm currently a doctoral student at the Harvard School of Dental Medicine. As Annalise mentioned, I have no financial relationships or conflict of interest to disclose. So when we look at a map of the US and see where the dental schools are at, it's one of the first things that stood out to me was that there's this whole belt in the Midwest where there are no dental schools. And so the broad objective of dental education programs is to develop future practitioners and specifically to educate students to serve their patients and communities. In 2021, the United States had 68 accredited dental schools with over 25,000 students enrolled in predoctoral dental education programs. The class of 2020 had 6,609 graduates, which is an increase from 6,350 in 2019. The dental workforce is steadily growing, as are the dynamic needs of this population. So if we look at the distribution of dental schools, there are three main types of schools. There's the public schools, and private state-related schools. And here's a map from the ADEA about it. Before we dive further into the presentation, I wanted to just go over a few terms that I'll be talking about. First is the intra and interprofessional learning. Intraprofessional is when students from two or more professions or within the same profession respectively learn about, from, and or with each other. This is really crucial for effective interdisciplinary collaboration, or what we're moving towards known as integrated care. Value-based care. Value-based care is the expectation that payers will eventually move away from a fee-for-service or reimbursement model towards an alternative payment model. Here, there is global payments or bonus and incentive payments made for to provide services as a whole instead of a fee-for-service driven model. This is a patient-centered approach to healthcare delivery, and it's designed to improve health outcomes and lower the cost of care. Health equity, many of you may have already seen this figure or something like it before. Oral health is a critical but frequently forgotten part of the equation when we talk about a person's health. And here we've seen that despite several efforts, oral health has been often neglected, and oral health equity means that everyone has a fair and just opportunity to be as healthy as possible, and this includes oral health. So to give you some background on why we chose this topic, the American Dental Association's Council on Dental Education, commonly known as CODA, is recognized as the accrediting agency for dental and dental-related education programs. The CODA's mission goals are to protect the public welfare, to promote an educational environment that fosters innovation and continuous improvement, to guide institutions in developing their academic programs, to guide site visit teams in making judgments regarding the quality of the program, and to provide students with reasonable assurance that the program is meeting its stated objectives. So this first point here, to protect the public welfare, that's really what I'm going to be focusing on. These are some of the related CODA criteria that were relevant to my study. The dental school must develop a clearly stated purpose or mission statement appropriate to dental education, addressing teaching, patient care, research, and service. So CODA really tries to increase an emphasis on how the schools need to create an environment that promotes interpersonal communication skills and to function successfully in a multicultural work environment. So the way that we did this study was that the three fellows, Amrita, Tooka, and I, we reviewed the 68 dental schools' websites, and we emailed the schools for additional information and clarification, and also compared this data with IDEA and ADA reports. We looked through the website because really the website is the first point of contact for anybody who's interested in either going to dental school or wants to learn more about the resources available to them if they're currently students. And it is also a source of information for patients if they're looking for a community program or if they need to go to get some treatment. This is one of the areas where they would look in for more information. These are some of the program structures that we were the variables that we looked at: the type of school, whether the school had a formal dental public health program, the number of faculty and students, and whether it was a research institution. In terms of training, we also looked at whether they do IPP or IPE and integrated training. We looked at community engagement, their diversity, equity, and inclusion focus, and value-based care. The way we did look for the trainings was if the schools had listed any CE trainings on any of these topics. As for DEI focus, we also reviewed the school's mission, vision, and goal statements and to see if they had any DEI leader identified for the school. So here's an overview of the results. Faculty, as you can see here, this purple segment, 100 to 500 was the most, followed by less than 100. And for students, 200 to 500 was the most number in all the schools. Again, just to clarify, we got these results from the school's websites, and there may have been discrepancies in how some of the schools listed these numbers. Some schools included part-time faculty and volunteer faculty, whereas some did not. So we'd have to keep that in mind as we look at these numbers. It was also interesting to note that most of the public schools and private schools did not have a specific DPH program. 23% had a DPH program of all the schools that we looked at. About 10% of them offered DDS or DMD MPH dual programs. 96% of all the schools were considered research institutions according to the Carnegie classifications for research institutions. And just a note, as I go through the rest of the results in my slides, I'm using the color gray to show less than desirable numbers. When I looked at the CE trainings, 22% of them had CE trainings on integrated care. Only about 16% jointly trained their medical and dental students. More than half the schools promote interprofessional training or said that they promote interprofessional training, and 66% have an IPP, IPE leader, and almost half the schools promote interprofessional training through CE programs. Over half the schools have a DEI program specifically for the dental school or their oral health program. This number was much higher in public schools compared to private schools. Only about 15% of the schools listed equity in their strategic plan, and 21% listed equity in their school's mission, vision, or objective. About 13% of them listed conducting continued education on value-based care. This number was again higher in public schools compared to private schools. About 3% of the schools listed it specifically in the context of substance use disorder and emergency care. Schools have a large community impact. About 83% of them have community clinics as part of the dental clinics programs, and 77% have them as part of extramural or rotations. So as I mentioned before, the schools, the students who are coming into schools are a growing diverse population, and though the proportions are about the same from 2013 to 2018, this figure is from EDIA, though the proportions are about the same, we can see that some of these percentages are on the rise. So while majority of the schools offer IPP or IPE training, it also seems like there may be an opportunity for improvement in terms of integrated care training. The schools, as we saw, have a large impact in their community through their community clinics, and public schools are doing better than private schools for establishing a DEI program in the dental school. There were some opportunities for improvement. Some of those were increasing the support on value-based care training, improving the focus on training medical and dental students together, and to revise the strategic plans on the websites to update the school's mission, vision, and goals to accommodate the changing student population needs. I'd like to focus on some of these a little bit more. First, when we think about value-based care, the reason why schools are thinking about the shift to value-based care is because the fee-for-service model is the current payment model, and it's been in use for the past 150 years. there's been no link to value or quality resulting in a higher volume of service. And this is something that has been in constant debate for several years on how we could reduce the cost. So first, if we even want to transition towards a value-based care model, is to actually understand all of its tenets, and by studying both the fee-for-service models and the value-based care model. And to help ensure readiness, we must understand how each model is defined and what cost and quality outcomes they're designed to produce. Another opportunity for improvement was the lack of coordinated care. Improving this lack of coordinated care could lead to integrated care. Right now, there are separate medical and dental care. And if we've seen in the COVID-19 model that integrated care can really benefit the patient, but if we do not have sufficient training, the students are not trained enough on opportunities for integrated care and how they can have a team-based approach in their clinics. So the conclusions were, as we just went over some of the highlights of our findings, some of the limitations, one thing is that the website updated would be dependent on the resources available to the schools. Some schools may have more resources allocated to updating the website. They may have a social media person who's responsible for it. But again, as I mentioned before, the website is really the first touch point for both students and for patients to look at and learn more about the services offered in the school. And the next steps for the study would be to do a mixed methods research study where we'd survey the schools and get more accurate data and also potentially do interviews with dental schools. I'd like to thank AIDPH, especially Annalise and Jasmine, for their support during this fellowship program, and also to Dr. Anthony Palata for all of his expertise and guidance. I'd like to thank my co-fellows, Dr. Amrita Tembhe and Tooka, for all of the work they did in doing the environmental scan with me. Thank you, CareQuest, for providing this opportunity, and also to the Harvard School of Dental Medicine program staff for supporting me.
Hello, everyone. Hi, Katie. I'm just having trouble proceeding my slides. Yeah. Thank you so much for doing that. Thank you. Thank you, Nithya, for that great presentation. Yeah.
Amrita, Katie can just advance your slides. If you want to just tell her.
Yes. Katie, could you please do that for me? Thank you. If we could go back to my first slide, please. Yeah. So let me start by thanking Nithya for that great presentation. And hello, everyone. I'm Amrita Tembhe, and I will be presenting on the topic of environmental scan of oral health journal publication processes. Next slide, please. Before we begin, I have a disclosure that I have no financial relationships or conflict of interest to disclose. Next slide, please. So today I will be giving you a brief introduction about translational science. Then I will be presenting the highlights from environmental scans of oral health journals, results, implications, and conclusions. Next slide, please. These two definitions on translation and translational science are provided by National Center of Advancing Translational Science. And translation is defined as the process of turning observations in the laboratory, clinic, and community into interventions that improve the health of individuals and the public, from diagnostics and therapeutics to medical procedures and behavioral changes. And translational science is defined as the field of investigation focused on understanding the scientific and operational principles underlying each step of the translational process. On the right, we have the translational science spectrum. This spectrum represents each stage of research along the path from the biological basis of health and disease to interventions that improve the health of the individuals and the public. This spectrum is not linear or unidirectional, and each stage builds upon and informs the other. Next slide, please. The process of translation is multi-stage and complicated. And research has documented that there has been a consistent finding that the transfer of research to practice is often a slow and haphazard process. And the studies have documented a gap of 17 years between research and practice. And as depicted by this diagram, we can see that there can be loss of knowledge at various stages in the translational process. Next slide, please. So we decided to focus on one of the aspects of translational process, which is journal publication, and how the factors involved in journal publication affect the translational process. For one of our projects, we looked at the environmental scans of the oral health journals. And today I will be presenting the findings from the environmental scan. The aim of the environmental scans of the dental journal was to acquire information to identify and interpret potential trends in oral health journals. We included top ranking 48 journals as assessed by SkyMyGo Journal and Country Rank. Next slide, please. So talking about the methods, data was collected from the websites of the dental journals, and information was collected on all 48 journals. Information was collected on various elements, including but not limited to the H index, editors of the journal, editorial team, supporting organizations, open access fee, review speed, acceptance rate, focus of the journal, subscription fee, and other fee related to the journals. Next slide, please. So why did we consider these factors? The H index and the impact factors, these are the metrics that measure productivity and citation impact of the publications. For editor and number of members on the editorial team, research has documented a relationship between author's decision and social relation and potential effect on the review speed. Supporting organizations, affiliations and reputation often affect author's decision while selecting a journal to submit their work. A focus is the alignment with the focus of the journal is the alignment with the research topic. It helps to answer questions such as if the journal is in alignment with the topic the author is wanting to submit or present, or if the journal has previously presented or published research on the author's topic. And review speed and acceptance rate, these are the important criteria for authors, especially when there's time constraint. Subscription fee and article access fee could result in financial barriers to access and thus affect the translational process. And open access and other submission fee could impact author's decision for submission, especially if cost is a barrier for new authors with limited financial resources. The limitations that we faced were missing information, and also we were not sure if the information available on the website was current and up to date. Next slide, please. So diving into the results, the first factor that we looked at was the primary focus of the journals. And it was seen that 20.45% of the journals published research on all aspects of dentistry. For the category of other, the journals published research on aesthetic dentistry, adhesive dentistry, and molecular basis of oral health and craniofacial disease. Next slide, please. The other factor that we looked at was the review speed of the journals. Depending on the time it took to get to receive the first decision from the journal, the variable was categorized into three categories. The first one being up to 1 month, 1 to 2 months, and more than 2 months. It was seen that over 55% of the journals took up to 1 month to convey their decision, and over 32% of the journals took more than 2 months. Next slide, please. The other variable we looked at was the subscription fee of the journal. Depending on the amount, the variable was categorized into no fees if there was no subscription fee for the journal, less than $200, $200 to $400, $400 to $600, and more than $600. It was seen that around 36.59% of the journals had a subscription fee of $200 to $400. Next slide, please. And the other factor that was considered for analysis was article access fee. Depending on the range of the fee, it was categorized into three categories. The first one being up to $20, $20 to $40, and over $40. It was seen that over 40% of the journals had an article access fee of up to $20. Next slide, please. The other factors we looked at were open access fee information, acceptance rate information, the number of members on the editorial team, and the relationship between number of members on the editorial team and the review speed. We found that 75% of the journals were US-based and 25% the remaining 25% were international. Due to unavailability of the information on open access fee, we could only get the information on 50% of the journals, and 50% of which had over $2,000 open access fee. Acceptance rate information was available only on 36% of the journals, and average acceptance rate was 29.7%. By looking at the relationship between number of members on the editorial team and review speed, we found that there was no relationship between these two factors. And the other challenge that we faced while looking at these factors, it was a lack of information on the journal's websites. Next slide, please. So talking about the implications, we could see that only limited number of journals had the focus on public health dentistry, oral health education, and oral health for special needs population. This limits the availability of options to the authors who are interested in research in this area, and which in turn affects the translational process. Factors such as slower review speed and lower acceptance rate would potentially discourage the authors from submitting their work to particular journals. And subscription fee and article access fee could be barrier to access of information to individuals if there are financial constraints and they would not want to subscribe to various journals, and which in turn limit the transfer of knowledge. Next slide, please. So to conclude, I would like to say that translational science in dentistry is the need of the hour to improve the overall oral healthcare. It is multi-stage and complicated, but measures can be taken to bridge the gap between research to practice. And transparency at various stages could really support the process of translation. Community and patient involvement is critical for the process of translation. Improving research methodologies, innovative partnerships, education and training, and organizational level support are some of the strategies to encourage translational science. Next slide, please. These are my references. Next slide, please. And I would like to share that this presentation is a part of project of a collaborative work between my co-fellows Nithya and Tooka. And it has been a pleasure working with these two exceptional public health professionals. And I am grateful to American Institute of Dental Public Health and CareQuest Institute for providing me this opportunity to work with this team and present our findings in this presentation. My special thanks to Dr. Annalise Cothron for her guidance during this fellowship. This fellowship has been a rewarding experience, especially with the mentoring session where we got to expand our network and learn from the experts. And I am thankful for the opportunity to explore and learn more about translational science in oral health, healthcare equity, and value-based care. So thank you so much. Next slide, please. Thank you, everyone. And this is my QR code with my information. Please scan it to stay connected. And now I would like to pass it on to my co-fellow, Tooka, to talk about the next topic. Thank you.
Great. Thank you, Amrita. Let's see if I have control. Yes. Okay. So I'm excited to share the preliminary data on the role of dental journals in translational science. And our learning objectives from this portion is to try and understand the role of dental journals in translational science, identify the influencers of publication focus, and explain the intended target audiences of dental journals. As a disclosure, the following information was gathered with a blinded survey to journal editors, but their specific journal or name was not included in any of the data analysis. I am an employee of the American Dental Association, but I'm not affiliated with their journal. And the survey to dental journal editors did receive IRB approval. And I know Amrita dived a little bit into what translational science is and research, but really a goal of the dental journal focus is to see how discovery is translated through journals, and then how that information is then utilized, reevaluated, and then translated again through journals. So really there's this academic discovery translation happening with the scientific journals. And this is how we get new ideas, not just for the clinical setting, but also for basic social sciences as well, and community programs. And there is some evidence right now on translational evidence that the innovation in public sector institutions, universities, hospitals, and private sector firms, a lot of their innovation does rely on findings that have been published, what is publishable. There are opportunities for publication, and that is sometimes what can influence a focus of investigation or a pilot program or an intervention. So there are other studies that also have found that engagement in clinical translational science, it can be motivated by perceived need, and perceived need can often be driven by scientific journals. So our question is, what are the drivers of oral health evidence in translational science? The image on the right is kind of showing how, there's an idea, it can go into a pilot study or case study, evidence is collected and analyzed, and then that key piece, the findings are published and the evidence is shared, and the cycle continues. So it is positively reinforcing itself as a loop. Our methods for today's findings were based on an environmental scan of oral health journals. The co-fellows and I went through publicly available data and some inquiries to dental journal editors and reached out to 48 dental journals. And we also utilized SurveyMonkey to survey dental journal editors from the environmental scan we conducted. The evidence collected is exploratory. It's part of an ongoing study, and we're going to dive into some of the preliminary results. But we are still collecting more data. When looking at equity and accessing translational science, a very key piece is the financial aspect of being able to publish and make the evidence collected open access. Our scan with 21 different data points of oral health journals found that the average open access cost for dental journals with a fee was $3,274. And the range of those went from $1,500 to $3,790. For journals with open access, for the oral health journals we looked at, 21% didn't have a fee for open access, but almost 80% did. As part of our qualitative review of dental journals, we see that dental journals and their editors, they are significantly influential in translational science. That was our foundation. So now we're trying to figure out what kind of influencers influence the dental journals and their key role in translating the evidence to the lay population. And the survey is part of a mixed method ongoing study. The following slides focus only on the survey portion. Part 2 is going to focus more on qualitative interviews with journal editors. We're so thankful for their time and the expertise and experiences that they are sharing for us to figure out the big picture. And the focuses that we have for the survey were the intended target audience, perceived open access quality, null hypothesis publication, influencers or possible influencers of publications, and topic prioritization. When asking about the target audiences for the dental journals that responded, 66.67% target audiences are dentists. And dental specialties, so dentists and specialized oral health providers made up 16.67%. And then clinical dental researchers was another 16.67%. There were options to select when looking at target audiences, and it's important to note that health policy professionals, primary care providers, public health professionals, and the general public were not selected by any of the editors that responded to the survey. So while oral health topics are being published, the main focus and target are the practitioners and the researchers, not so much the public health, population health professionals, although they can be both. This was very interesting when looking at perceived open access quality. The journal editors that responded perceived the quality of open access articles and closed access articles in their own journal to have the same quality. However, when we asked about the perceived quality of open access articles and closed access articles in other journals other than their own, there was another portion that said the open access had poorer quality. 1/3 of respondents perceived that other journals had poorer quality open access articles. When looking at null hypothesis data, we wanted to see, how does research involving non-hypothesis data or non-significant results influence the journal's review process? We see this, for example, with fluoridation studies, where there may be no difference seen with fluoride or fluoridation exposure and any sort of significant outcome, and that would be considered a null hypothesis. How often do the dental journals surveyed publish null hypothesis data? The minimum that we found was about 22% of the time, while the maximum was 86% of the time. But when taking an average across the board, about 50% of the time, null hypothesis data would be published. And when asking about, what's the perception of null hypothesis data, we highlighted a few quotes that I'll read. So the first is, peer reviewers are generally less enthusiastic about studies without significant differences. That's considering that a null hypothesis data isn't considered significant. And that's a very interesting point. Another is, there is some influence, but it is left up to the reviewers with added influence at levels of associate editors and the editor. And finally, I don't think it substantially influences the review process. This was a significant area of interest that we surveyed about. It was the substance use disorders publication since the CODA requirement 2-24 that came out in 2017 for required substance use disorder training. The reason we asked this question is because there's a possible perception that CODA can significantly influence publication focus, and we wanted to see if that was the case through this survey. 50% said no, they did not publish on this substance use disorder topic since the CODA requirement, while the other half said that they published, not so sure about the call or did not call for abstracts. So there was no significant influence of the CODA requirement on substance use disorder publication. And when looking at the factors that impact prioritization of topics for publication, we offered options, and also individuals could enter their own, but there was one that was very highly reported as a factor to impact prioritization, and that was a novel topic, something new, something that hasn't been published before. And that's also interesting because in oral health sciences, sometimes the lack of reinforced information can make it difficult for a public health program to be implemented if there's only one study on it. But the novelness of a topic was a very high factor for prioritization. The next most reported topic was clinical research. As we saw, dentists and dental researchers were a target audience, so that's not surprising. And then the next two were opportunities for medical dental integration and emergent need. The other items below had very low reporting, but I'll read them because I know it's really small. So it was CODA standards, Healthy People 2020-2030 standards, a replicated topic, a health equity topic, and health policy changes. All those are directly related to public health and population health, but aren't necessarily impacting prioritization. So what does all this very preliminary data tell us? Oral health journals, they're influencers of dental best practices and programs, and they're largely targeting dental practitioners rather than health policy and public health practitioners. Open access is perceived to be of poor quality when not from a journal editor's own journal. Null hypothesis data is published about 50% of the time. Novel topics and clinical research are the biggest reported factors in topic prioritization. And dental standards such as CODA and Healthy People, they're not significantly influencing topic prioritization for dental journals. So the investigation is going to continue. We're excited to get more insight into the oral health journal's role in translational science. But this has all been possible with the American Institute of Dental Public Health and Dr. Annalise Cothran. They've really supported learning more about how evidence is shared and that translational science cycle. Big thanks to the journal editors that completed this survey and the journal editors that are doing qualitative interviews with us to help us learn more. And of course, co-fellows Dr. Amrita Tembhe and Dr. Nithya Ramesh. Outstanding fellows to work with. So glad I had this opportunity to learn alongside them and do the environmental scans with their expertise. And of course, the CareQuest Institute for Oral Health. That is my QR code for you to get my contact information. Always happy to connect about anything dental public health. And I think Annalise will take the floor.
Thank you so much, everyone. So we are now going to take questions. So I'll invite all of the presenters to turn on their cameras and we'll go ahead and close out of the presentation. And if you have a question for any of the presenters today, please put that into the Q&A box. I see one already, and that is from Scott Tomar, asking about essentially how did we select the journals, recognizing that open access journals can have what they call predatory publishers. And so just giving a little bit of insight about how and why the journals were selected.
Yes, we looked at their scoring and we did a deep dive into the journals, their either overarching affiliation, and we looked into what reputable organizations that they were affiliated with. We looked at 48 different journals and we sent out requests to all of them. It really, there could be a good point to make about response bias as well, because while we reached out to all the editors, not all of them have responded yet. We definitely are keeping in mind kind of the predatory publication and trying to make sure that when we are reaching out to these journals, that they are either affiliated with an oral health organization or have a professional affiliation of some sort, and looking at the editor and editorial board as well. Part of the co-fellows presentations also looked at diversity within these different journals and seeing the different professions that they are affiliated with and the diversity within the editorial board to make sure that it is a significant publication source.
And not all of them were open access, just to be clear. I think only a small proportion of those that were included in this were full open access. The bulk of them were not.
21% of them had open access, and those are either because of their affiliated organization or supporting the open access fee.
Awesome. So I have a question for the fellows while we're still sort of having our Q&A open. I'm interested in hearing what the most surprising result was that you all uncovered either during your experience or, our discussions, through your mentor sessions, or through your exploratory research. And we can just go whoever would like to popcorn and answer that question first.
I already spoke, so I'll let either Nithya or Amrita go.
For me, I think it was about the focus of equity in the dental schools, or the lack of focus on equity in the dental schools' mission and objective. Given that CODA expects there to be some sort of statement in the mission statement for the school, I found it surprising that only about 15% of the schools had it listed in their strategic plan and in their mission and vision statement. So, maybe, like I said, maybe it's something they've just not gotten around to update on their website. But that was surprising to me that such few schools had that on.
Yeah, and for my part of the presentation or my part of the project, looking at the environmental scans, what I find surprising was there was limited information on very important factors such as open access and acceptance rate, and which are really important in terms of for authors to make the decision while submitting their work. So I really feel that being transparent about these factors would be really helpful for the process of translation.
Good answers. I think my focus was trying to figure out more on how publications are influenced and what are the drivers. And I was actually pretty surprised to see that a lot of the public health related topics and health equity topics were not a priority, and that CODA standards and healthy people standards that you would assume would drive a focus, at least for those that responded to the survey. There's, again, small sample size, but that it wasn't a significant factor in that novel topics. While I've heard, of course, you want new, that especially in something as nuanced as practitioner standards and best practices, that sometimes replicability can reinforce the significance of a finding. And if the focus is always to find something novel, then how are we going to strengthen existing data? I see this a lot with fluoridation, dental sealants, again, those public health programs. So it kind of seemed like there was some sort of divide there with what would be expected and what we found. But the lack of finding a lot of the data in public spaces, that wasn't too surprising for my end, because I do know a lot of this, it's not very publicly shared. A lot of it happens kind of behind the public sphere.
Yeah, and to add to what Tooka and Amrita just said, even for the dental schools, the information about the number of students the program accepts was not publicly available. We had to do a lot of digging to even just guesstimate how many people the program takes based off of like previous cohorts or some other information like a proxy measure for it. So it was really interesting. I'm trying to think of the rationale between why the school wouldn't want their school size to be known publicly. And maybe it's because they want to encourage applications, and if they have lower acceptance rates, maybe they don't want that to be a deterrent for applicants. But that was also, again, another thing that was not publicly available or easily available.
Mm-hmm. And I see a question in the Q&A that I could answer. I don't know, Annalise, if you want to, if that's okay.
Yes, absolutely. So there's a question about what recommendations we may have for practitioners who want to publish, but may struggle with some of the barriers that we mentioned, either with, I'm assuming, slow publication times, or maybe trying to find the right outlet for publication. Are there any recommendations that your results led you to make?
Yeah, I mean, for my end, seeing that the dental journals that responded weren't maybe going for topics related, again, depends on what your topic is, but even though it may be oral health related, if it's not related to the kind of target audience that a lot of these journals are looking at, to maybe bring in oral health into journals that are looking more into target audiences of public health, health program, community health. While of course we want it to be in a dental focused space, if you're looking at a public health program that's related to oral health, rather than maybe focusing on a dental journal, to look at journals that are looking into public health, public programs, community health. I don't know if others have other ideas. Okay.
I'll also just add, reaching out to journal editors. If you can find their contact information, is super helpful if you're looking to publish. Most of the time, journal editors want to see articles come in to their, and we've heard that now reflected in our interviews that we've been doing. Most of them are very excited to get new information and are happy to give feedback on that process. So while some areas may not be transparent, I think that journal editors really want communication and transparency and kind of facilitating that process.
And, another note, since the findings did find that a novel topic is a huge driver for publication, if you have some really great data, but it may be somewhere else as well, to really highlight how your perspective is different and highlight the nuance and the novelness that your data can bring to the table, even if it's replicating maybe similar results somewhere else, and that's a barrier. How's the population that your findings influence different? How is the way the data was gathered different? It seems like that's a big driver.
Okay, well, I am not seeing any other questions in the Q&A or in the chat. So I would like to, thank everyone for being here today, but most importantly, thank our fellows. I've had the pleasure of working with them now for the past 2 months and maybe 10 weeks. And so it's been really exciting being able to work with them. This group of fellows has a really bright research career trajectory ahead of them. And AIDPH is happy to support that career trajectory. And I know that we actually have some attendees here who served as mentors through our program. So thank you for being here as well. But if there are no more questions, we'll go ahead and conclude our presentation today. There is a link to the program evaluation and CE request in the chat that Katie just put in there. Thank you, Katie. And we will also be recording this and making it available on our YouTube channel. While you cannot request CEs, if you watch the recording, you can still get all of the great information and share with your community. So thank you all so much. We'll conclude the webinar for today. We appreciate you attending.